Hi, I wanted to share my technique for the Xen Stent. This case is done in combination with cataract surgery. We've just placed the intraocular lens and we're getting ready to place the Xen Stent. I have been doing the Xen Stent now for approximately 2 years. This is my experience after 100 cases or so. Here I'm applying tetracaine to the superior conjunctiva. I use a Wexel sponge soaked in tetracaine. I've had a few patients who had issues with the Mitomycin C with some discomfort with that. I used calipers to mark 2.5 millimeters posterior to the limbus, which is where I want the Xen Stent to come out. And this is a very important step here. I use a marker to just ink the top portion of the Xen Stent so I can see it going in. Also important note, I secure the eye using 0.12 forceps in the paracentesis. It's really important to be able to secure the globe here, whether it's with a Vera hook or corneal traction sutures. My initial pass here seems a little bit superficial, so I retract the needle. I've not gone all the way through sclera, and I go a little bit further posterior. And just this is probably one of the most crucial parts of the surgery. You want to come out at the right distance from the limbus, as well as come out as superficial as you can without puncturing the conjunctiva. You advance the Xen Stent. As you advance the Xen Stent during this part, it's really important to relax your hand, completely relax your hand so there's no tension and decrease the risk of flicking the Xen Stent or removing it as you separate the injector. The Xen Stent's in place. The conjunctiva has not been touched so far. Here I'm going in and removing the viscoelastic material. And you'll see as I do this, there's a bleb that has formed. We hydrate the wounds, make sure we have a stable anterior chamber. And now that a bleb has formed, there is space to perform a primary needling. This is a 30 gauge needle. There's Mitomycin C in the syringe, and I pass the needle several times above and below the Xen Stent. This primary needling step has been important in terms of improving the success of this procedure and decreasing the needling rate later. Once I'm happy with that, I will go ahead and inject the Mitomycin C. Here I'm injecting 60 micrograms total, so Mitomycin C is diluted to 0.4 milligrams per ml, and I inject 0.15 cc's. We irrigate the cornea here, irrigate the ocular surface, and then we push back the bleb from the limbus and push back the Mitomycin C from the limbus. After injection of Mitomycin C, I also use Kenalog in the bleb. This is Kenalog 10 milligrams per ml, and we inject just a small amount. Just both Mitomycin C and the Kenalog are to help prevent bleb fibrosis later. To summarize, I found the Interno technique to have the most reproducible results, and I wanted to share some of the pearls I've learned along the way. Thank you very much.